So shall we start?
Good.
Shall we start?
Sir, shall we start?
Just one second. Yeah, good evening to all of you. I request Ranjan is the only person who is available. Dr. Ranjan, our secretary. Just relax. Dr. Ranjan, good evening to all of you. Dr. Ranjan is the secretary.
Good evening, sir. Good evening, both teams. This is the second day. This is the second day of the quarterfinals, and all the best to both the teams.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
So now Gokulam, make the presentation, please.
Okay, sir.
Your time starts now.
Yes, sir. Okay, sir. Good evening, all. A 38-year-old patient, Mr. Rahul, who is a mason by occupation, coming from Venyaramud. He presented with swelling in the right groin for the past 2 years, which has now extended into the right scrotum. History of present illness. The patient was apparently normal 2 years back when he noticed a small swelling in the right groin. It was insidious in onset, initially small and confined to the groin. Over the past 1 year, it has progressively increased in size and now descends into the right hemiscrotum when he stands or walks for a long time. The swelling prominently appears and increases in size on coughing, lifting heavy weights, and straining. It reduces completely when he lies down. He experiences a mild, continuous dragging sensation in the groin by the end of the day. No history of any irreducibility, no history of severe pain, vomiting, abdominal distension, or constipation. History of chronic cough present. No history of chronic constipation or straining at stools. No history of lifting heavy weights recently. Past history, no known comorbidities. History of open appendicectomy surgery done 20 years back. Personal history, non-vegetarian diet, bowel and bladder habits normal, sleep and appetite normal. He's a chronic smoker since the age of 24, 10 cigarettes per day, smoking since 14 years and pack years 7. General physical examination, patient is conscious, cooperative, well-oriented, height 164 centimeter, weight 60 kg, BMI 22.3 kg meter square, vitals are within stable. Head-to-toe examination, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Local examination of the groin and scrotum. Patient is examined in a well-lit room, properly exposed from the umbilicus to mid-thigh after obtaining consent, first in the standing position, then in the supine position. Inspection in standing position. A single vertically oval pyriform swelling measuring approximately 12 into 8 centimeter present in the right inguinoscrotal region. It extends from the right inguinal region down to the bottom of the right hemiscrotum. The overlying skin is normal, no redness, scars, dilated veins. Expansile cough impulse is present. Left groin and scrotum appears normal. There is no visible swelling. An inspection in supine position on lying down, the swelling reduces completely. Palpation in supine and standing position. Confirmed inspection findings regarding the extent. Normal temperature over the swelling. There is non-tender swelling. It is not possible to get above the swelling. An expansile cough impulse is palpable. Deep ring occlusion test. After completely reducing the hernia, deep ring is occluded with the thumb. The patient is asked to cough. The swelling does not appear while ring is occluded. Upon releasing the thumb, the swelling immediately descends obliquely into the scrotum. Zeeman's 3-finger test. Impulse is felt over the index finger. The swelling has a doughy consistency. Testis is bilaterally palpable. Penis is pushed to the left side. Percussion, dull note over the swelling. Auscultation, bowel sounds are not heard over the swelling, but abdomen, bowel sounds is heard. System examination, a right side incision scar of previous appendicectomy is present. No incisional hernia over the scar site. Abdominal tone, overall abdominal muscle tone is fair. No hepatosplenomegaly or ascites, no other palpable swellings. Digital rectal examination, rectal mucosa is free, anal tone is normal. Respiratory system, bilateral vesicular breath sounds heard. Cardiovascular system, S1, S2 heard. Normal. Case summary, Mr. Rahul, a 38-year-old male, chronic smoker, presents with a 2-year history of a reducible right-sided inguinoscrotal swelling that increase in size on straining and standing and coughing. Examination reveals a completely reducible right inguinoscrotal swelling with an expansile cough impulse. impossible to get above the swelling, and deep ring occlusion swelling appears on releasing the occluding finger on coughing, and systemic examination within normal limits. Provisional diagnosis: right-sided, uncomplicated, completely reducible, complete indirect inguinal hernia containing omentum as content, precipitated by smoking-induced chronic cough.
Very good presentation.
Thank you.
So,
Go on, you have 10 minutes. Sorry, you have 20 minutes.
yes, sir. So why did you come to your diagnosis?
Start. The patient, on clinical examination, there is a pyriform shaped swelling of 12 into 8 centimeter over the right groin region, and it is extending. It is extending to the right hemiscrotum also, and the cough impulse is positive. Yes.
And just can you tell me some characteristic features of hernia?
It is a cough impulse is present. It is a completely reducible swelling. It is extending from the right groin region to the right hemiscrotum also.
Impulse on coughing and reducing it.
Yes.
So, from history, what are the points were suggestive of it's an indirect hernia?
First of all, age of the patient. He is only 38-year-old patient. In younger age, it is indirect inguinal hernia, which is more common than the direct one. And in the history-wise, he is a smoker. So, smoking is also a risk factor for inguinal hernia.
Does it not descend down to the scrotum? Is an indirect hernia usually descend down to the scrotum?
Yes.
Direct hernia, it is less common.
It
And
is
also
common.
here to reduce direct hernia. And it's
Yes.
In your patient, the hernia comes to the scrotum while he is walking, and you said it is completely reducible.
Yes.
Whether it is spontaneously reducible or the patient manually pushes it inside.
Spontaneously reducible
Spontaneous.
by lying in supine position.
Inguinoscrotal swelling, which reaches till up to the base of the scrotum, while lying down, it is spontaneously reducible for your patient.
It is reaching up to the upper pole of testis.
It's actually funicular type.
It is funicular type, and when he lies down, it
I know
completely
you said in your diagnosis, but you mentioned it's a complete hernia.
It's upper.
This is a funicular type.
You mentioned pain in your history.
Yes.
What type of pain do you expect in this patient, and what is the cause?
It is a dragging type of pain, which is mostly felt at the end of the day.
why
Why?
does it occur?
Because it is usually occurring because of the pull of the peritoneum along with the inguinal contents, causing dragging type of pain.
What are the other kinds of pain that can occur
Patient will be having severe pain over the inguinal hernia in case of strangulation.
Destruction.
Is
Severe.
it the hernia or is it the entire abdomen?
It is in the
It is in the mainly in the hernia
hernia
side, hernia
Mainly
region.
over the hernial site. Once it reaches into generalized peritonitis, it can spread into the abdomen.
Surrounding
And
abdomen.
especially the pain can also be colicky as well.
And also because initially there is stretching of the muscles also, that is also contributing towards the pain, not just the peritoneum and the mesentery.
What is the duration of chronic cough in your patient?
He's having cough since 1 year.
So your
But
history-
his hernia is there for 2 years you have presented, but his cough is for only 1 year. That during the diagnosis you mentioned it is secondary to chronic cough. How can you explain that?
I know chronic cough patient has complained since 1 year. After starting of that cough, the swelling started to extend into the scrotum also.
Because indirect inguinal hernia usually may be congenital component also. It may be more
Definitely.
apparent when the
Yes.
patient starts to cough.
So, from history, he has history of smoking that causes the cough.
Hernia.
So, what is the smoking? Why does smoking causes hernia?
Because smoking is important, especially for the impairment of collagen, and because of that, the there will be muscle weakness, and the ring, deep inguinal ring, the muscle surrounding the deep inguinal ring will be getting weakened, resulting in indirect inguinal hernia.
What about cough precipitated by smoking?
It can increase the intra-abdominal pressure
Pressure and it can
that leads to
cause-
the contents being into the hernia.
What is the effect on collagen? Can you be more specific?
Actually, collagen, there are mainly 3 types of collagen. Of that, type 1 has to be there for good functioning. So type 3 is the weaker one. So in smoking and all, the type 3 will be more. Type 1 will be less. So
What are the complications of hernia do you expect in this patient?
irreducibility, obstruction, strangulation, incarceration,
and inflammation.
Can there be strangulation without any features of obstruction?
Yes, it can
Yes,
occur
it can occur.
Yes.
as
What are the
Richer's
what are the
hernia,
conditions?
Richer's hernia, there can be a strangulation without obstruction.
because a part of the bowel will be
it comes
trapped
to-
inside the hernia, which can cause strangulation.
No, but in your patient, you said bowel is not a content.
Yes.
In general,
Any other
Yes.
causes where
General.
there can be strangulation without features of obstruction?
No, we were talking in general terms, not in the case of our patient.
For this patient.
In this patient.
So you said momentum is a content.
Yes.
So when momentum gets strangulated, there won't be any features of obstruction.
Yes.
Yeah.
And
What is the importance of history of previous surgery? Here you mentioned appendectomy. Is there any importance?
Yes.
While being did an incision for appendectomy, there is a chance of nerve injury, which can later predispose to
ilioinguinal nerve.
What is the plane in which the nerve get injured? What is the plane through which the nerve travels during which an open appendectomy the nerve can get injured?
while traveling to the
It's in between the internal oblique and transverse abdominis. So if nerve is injured, what type of hernia is more common? Is it direct or indirect?
indirect, so direct hernia, weakness of the
Direct hernia. It is due to the weakness of the muscle.
Posterior.
So you mentioned family history. Can you mention what all risk factors there in family history?
patients with an inherent collagen muscular disease, especially the Ehlers-Danlos syndrome, they will be having weakened posterior wall because of the collagen maturation. So there is high risk of predisposing to hernia in these patients.
yes. You mentioned there is no history of irreducibility. Suppose your patient had a history of irreducibility. What changes in your plan will you make?
If there is irreducibility, it is an indication for it's an indication for surgical repair in this patient. It should be done after admitting the patient and should be done in the next possible day.
Okay, good. Then you.
What is Hasselbalch's triangle?
Hasselbalch's triangle is a triangle which is related to the direct inguinal hernia formed by the inferior epigastric vessels laterally, lateral border of the rectus abdominis muscle medially, and by the ilioinguinal ligament inferiorly, and it is the most common site of direct inguinal hernia.
Ilioinguinal ligament inferior.
Inguinal ligament inferiorly.
So inferior epigastric is a branch of which vessel? How many inferior epigastric are there?
There is superficial and deep inferior epigastric.
Can you name the vessel of origin of
iliac.
the
Different branch of iliac.
sorry, internal. Can you please specify once more?
Branch of external iliac.
Which vessel? Superficial or deep?
Deep.
Deep inferior epigastric. Deep inferior epigastric artery is a branch of external iliac. Then
Internal
superficial.
Internal iliac.
Let's go on to the next.
It's a branch of femoral.
Just you did not mention peristalsis in the hernia. There is no peristalsis.
There was no visible peristalsis. There was actually no visible peristalsis.
You didn't mention that. Why is it important?
Because
Whether to identify the content as intestine or omentum, to differentiate whether it is intestine or omentum as content.
Yes. Okay.
So in your examination, how did you expose the patient?
We have to expose the patient. We have to examine the patient both in standing and supine position, exposing the patient from the level of siphisternum up to mid-thigh.
So,
What is the mid-inguinal point?
Mid-inguinal point is the line joining, midpoint of the line joining, antisupplex spine, and the pubic symphysis.
Where is the deep ring located?
Deep ring is located 1.5 inch, 1.5 centimeter above the mid-inguinal point.
What is mid-inguinal point?
then
Midpoint.
in digital rectal examination, you said most of it was normal, but did you not you did not mention that there is no prostatomegaly? Isn't that important as well?
Yes, it is.
Yes, prostatomegaly.
Can you say?
Straining at urination, if there is prostatomegaly, straining at urination can cause
Increase the
abdominal pressure that can precipitate hernia.
So suppose if a patient has BPH or any prostatic problem along with hernia, what will your approach be?
Because
First we have to correct
initially we need to correct the prostatomegaly in the patient. We need to treat the prostatomegaly, then only we should need to.
Correct.
Only prostatomegaly symptoms you're asking for, anything else? Urinary symptoms?
We need to ask for nocturia, hesitancy, intermittency, straining, lower urinary tract symptoms should be asked for. And
Also prostatomegaly. Anything else? You can also ask for urethral stricture, gonococcal infections can cause stricture, phimosis,
Because it is
paraphimosis, all these.
young
Young patient especially with
So
hernia.
urethral pathology can also be a concern.
How did you
halfway
start?
through the month? Halfway through the month. 10 more minutes.
Yes, sir. Investigation.
How did you do a deep ring occlusion test?
So, first of all, we have to make the patient to be in supine position, reduce the swelling. Either it will get spontaneously reduced, or we have to ask the patient to reduce it.
Yes.
So, after reducing the swelling, we have to identify the deep inguinal ring and occlude the ring with our thumb. And we have to ask the patient to stand. And then we have to ask the patient to cuff. So, we have to look for any impulse seen medially to the occluded finger. If we are seeing any impulse medially to the occluded finger, then we can come to a diagnosis that it is a direct hernia. It is not.
What is the landmark for superficial ring? Surface
ring,
landmark for
It is
just above and lateral to the
medial to the
pubic tubercle.
where did you palpate the pubic tubercle? How did you palpate the pubic tubercle?
Pubic tubercle is palpated by tracing along the adductor longus muscle. Insertion of
Palpating the
Adductor longus.
tendon.
Tendon of
adductor longus muscle or tendon?
Tendon of adductor longus.
In what would you like to go on with your investigation? What is the management?
So,
Further
What further
investigation.
investigation?
so of course we need to do surgery in this patient because it's a young patient. So there is high chance of irreducibility and further complications in this patient later on. So it is better to offer surgical management as early in this patient. So
Yeah.
So after doing the pre-operative assessment, including the chest X-ray should be taken to look for any chest findings because of the smoking history, and we need to take a
Will you do US?
Ultrasound has to be taken.
Why do you want to take a USG in this patient? You already have a diagnosis, right? This is a
Yes,
direct.
it's a clinical diagnosis obviously, but for completion, for legal purposes, and also for
There are 20% chance there is a chance patient might have contralateral hernia.
hernias also.
Yes. So
Also
if
for
then-
confirming about the content and defect size also we can take for identifying the defect size and also confirming the content we can take a USG of occurrence.
For
No,
this patient, what all the findings are you expecting in ultrasound for this patient? For this patient, what are the findings you are expecting in ultrasound?
For this
Scan.
patient.
Yeah, for this patient.
In this case, we can identify the defect size and also what is the content and if there is any contralateral hernia.
And also look for the vascularity.
does
we are
not
not
have any
suspecting.
symptoms, right?
And also
Prostate
often-
also, urine volume, prostate cannot.
So what procedure will you offer this patient?
Current gold standard is to offering Liechtenstein
Tension-free hernia mesh repair.
So there are two scenarios now. One is patient presenting to you in a OP setting.
Yes.
One scenario is patient presenting you with irreducibility and severe pain in casualty setting. Any management difference will occur in doing Liechtenstein's repair, or any management? Is there any difference in management?
Yes,
Or
of course.
different approach
Because
you expect?
if the patient is presenting an emergency setting, and if you are operating the patient, if we find that if the patient is having any signs of strangulation, and if you are performing a precision anastomosis for this patient, we will not place mesh in that setting. Whereas if the patient is presenting in OPD setting,
So how will you assess the content? Is there any change in your surgical procedure?
Do you take any precaution so that the content is not reduced in a emergency setting? Any? No. While doing a surgical procedure, do you take any precaution so that the content is not reduced so that it does not retract into the abdominal cavity. What modification will you do?
You can medially extend your incision, and before opening the external oblique aponeurosis, you can catch hold of the content so that it does not slip off. Usually,
that's
the
not
content is the external ring, so it is an aid. Also, in Lichtenstein, you told me what are the where all do you fish the mesh in Lichtenstein?
In Lichtenstein head mesh repair, we will be after repairing the posterior wall, we will be fixing the mesh in towards the tissue over the pubic tubercle and towards the inferiorly towards the shelving edge of the inguinal ligament and medially towards the rectus sheath and superiorly towards the conjoint tendon. Laterally, the
Medially, will you fix it to the pubic tubercle?
Or conjoint.
Medially, is it to the pubic tubercle or?
Medially, medially to the pubic tubercle and inferiorly to the inguinal ligament.
Exactly in which part of pubic tubercle?
above the connective tissue, about 2 centimeter lateral to the pubic tubercle.
To prevent medial recurrence in Lichtenstein, you have to actually have a 2 centimeter overlap over the pubic tubercle. The most common recurrence is medial.
Medial recurrence.
Yes.
If you directly suture over the pubic tubercle, what will happen?
Periosteus.
So the peri-adventitial tissue just next to the pubic tubercle should be sutured.
So
Yes.
you mentioned Lichtenstein tension-free mesh repair.
Yes.
Why is it called tension-free?
Because we are posterior wall plication is done in a tension-free manner. We are actually approximating the transversal, plicating the transversal fascia, and we are not suturing the conjoint tendon to the inguinal ligament. We are actually plicating the transversal fascia and placing the mesh of
Any
the
other surgical options you can give other than an open surgery for this patient?
Of course,
Laparoscopic repair can be offered to this patient. Like
Which
TEP
approach would you prefer?
TEP or TAP
TEP or
can
TAP.
be done.
Transabdominal, preperitoneal, or totally extraperitoneal repairs can be offered for the patient.
Which would you prefer for this patient?
Can TEP be preferred in this patient?
no, because it is as it is extending into the scrotum, we will have to go for
Open repair.
Open. Why not TAP?
because there can be
You can also attempt to tap safely in this patient.
Yes, mostly this laparoscopic approaches we are giving for bilateral hernias or recurrent hernias and small hernias.
So suppose
No, in unilateral you can try because there is, as I already said, there is a chance patient might have an occult hernia on the bilateral side.
Oh, yes.
so it's better to go
So
for
if a patient presents unilateral hernia, you can also go for a lap repair.
Okay.
While entering into the abdomen, what are the peritoneal folds which you will be seeing? Name the 3 peritoneal folds.
Median umbilical fold, medial and lateral umbilical fold can be seen.
Can you say what are their contents? What
You
is
have
medial
2 minutes more. 2 minutes more.
Median
Median umbilical ligament is the remnant of urachus. Medial is the obliterated umbilical artery. Lateral is the fold of inferior epigastric vessel.
Suppose you have done a successful Lichtenstein tension-free hernia repair, but the patient comes with you with pain. What all do you suspect?
It is an inguinodynia.
There can be
It can
entrapment
be.
of the
Inguinal nerves.
by placing
what
the
all
mesh.
other complications can you expect in this patient in the immediate postoperative period?
There
Hematoma
can
is
be
most-
hematoma.
Hematoma is the most important complication, followed by there can be seroma formation, and there can be
Ischemic orchitis can be there. Wound infection can be there.
If the patient comes with
Which-
infection, what are you suspecting? What are you afraid of?
mesh infection.
Mesh infection can be there.
Mesh. What is the type of mesh that you use here in
Yeah,
your
use a-
Lichtenstein repair?
Synthetic mesh,
Synthetic mesh.
polypropylene mesh, which is
Is there any
light,
specific
Any other
characteristic that
characteristics do you want to add on?
lightweight,
Lightweight,
macroporous, synthetic polypropylene mesh.
some materials that are used for making mesh?
Any
Polyester
other materials other than polypropylene?
and polyester can also be used.
If the patient presents with a surgical site infection, do you always have to remove the mesh?
No, it is not needed.
We can
How
go.
else can you manage?
We can give the patient on start the patient on IV antibiotics, strong IV antibiotics, and followed by
Cultural
aggressive.
After culture and sensitivity, you can start on antibiotics, and after that, if it's only needed, a part of the mesh can be removed.
What is the most common bacteria involved in mesh infection?
Staphylococcus aureus.
It's a atypical mycobacteria.
Also, you can try negative pressure wound therapy also in
Okay,
fact.
so after that,
Can also be done.
Last question. Last question.
Suppose
Last question.
inguinodynia is occurring. What all nerve injuries are you suspecting? And is it always a nerve injury?
Inguinal occurs mainly because of the injury to the inguinal nerve, ilioepigastric nerve, and genital band, genital femoral nerve. So pain can also occur because of the ischemic orchitis also, or it can occur because of meschoma, which is a contracture of the mesh, which is causing immobility and other pain.
Or
in the
due to
patient.
periostitis.
Yes.
Thank you. GMC Kottayam can make their presentation.
Thank you, sir. Sir, shall we share the screen?
Yeah, please.
Yes, sir. Sir, is the screen visible?
Yeah.
Yes.
Go ahead. Go ahead.
So, presenting the case of Mr. X, 58-year-old male patient who works as a waiter and who residing in Kottayam, presented with the complaints of dilated tortuous veins in the right lower limb for the past 20 years and pigmentation of the skin over the right lower leg and ankle for the past 5 years. History of presenting complaints. Patient was apparently normal 20 years ago when he noticed dilated tortuous veins on the right lower limb below the knee. It was insidious in onset and increased in size on prolonged standing and decreased on lying down and elevating the limb. He also complained of pigmentation of the right lower leg and ankle over the past 5 years, which was insidious in onset, gradually progressive, and was associated with itching. So following this itching, he developed an ulcer over the inner aspect of the right ankle around 1 year back, and it was gradually progressive. With treatment, it took 6 months to heal. And it was associated with the intermittent episodes of dull aching pain for the past 1 year in the right leg, which aggravates on prolonged standing and relieves on lying down and elevating the limb. There was history of edema in the right lower limb for the past 1 year, worsening as day progressed and relieved on lying down and elevating the limb. There was no history of bleeding from the dilated veins, no history of bursting type of pain in the lower limb, no history of prolonged immobilization, no history of abdominal symptoms, no history of altered sensation in the limbs, numbness or weakness in the lower limbs. There's no history of similar complaints in the left lower limb. In the past history, he has no non-comorbidities. There's a history of appendicectomy done in 1990. There is no history of long-term immobilization. On personal history, he consumes a non-vegetarian diet. His sleep is normal. He has normal bowel and bladder habits. He is a smoker who smokes 3 cigarettes per day, which accounts to a smoking index of 90 and packets of 4.5. There's no significant family history in this patient. And treatment, he has been using compression sucking for this condition for the past 1 year, but not regularly. The ulcer was managed with the daily dressing, which eventually healed over 6 months. Summarizing, we have a 58-year-old male hotel worker with no non-comorbidities with complaints of dilated tortuous veins over the right lower limb for the past 20 years, with hyperpigmentation of the right lower leg and ankle for the past 5 years, and healed ulcer over the right gaiters area.
Moving on to examination, patient was examined after taking verbal consent in the presence of a family attendant. He was conscious, cooperative, and well-oriented in time, place, and person. His height was 168 centimeter, weight of 54 kilogram, and a BMI of 19.1. His vitals were normal on examination. There was no pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. Inspection of bilateral lower limbs. Patient was examined in standing and supine position with adequate exposure. The left lower limb appears normal on examination. Attitude of the left limb was normal. There was no deformity and he had a normal gait. There were multiple dilated tortuous veins in the anteromedial aspect of the right leg from the medial malleolar region up to the knee joint. There were no varicosities seen over the thigh and posterior aspect of the leg or the lower abdomen. The skin was stretched and dry with hyperpigmentation seen over the right lower leg extending to the ankle. There is a scar of a healed ulcer nearly 6 into 4 centimeter, which was present just above the medial aspect of the right ankle, with hyperpigmentation in the surrounding skin. These are the clinical pictures. Palpation. There was no local rise of temperature or tenderness. His limb girth was 20 centimeters in the right lower limb and 21 centimeters in the left. There were multiple dilated tortuous veins, anterior and medial aspect of the right leg, and the skin of the lower leg was circumferentially thickened. Brody-Trendelenburg test 1 and 2 was positive. Tourniquet test, there were dilated veins seen between tourniquet 2 and 3 and 3 and 4. Modified Perthes test, there was no pain. Fagan's test, there was a 1 centimeter defect in the deep fascia, palpated 20 centimeters from the medial malleolus, and 1.5 centimeter defect palpated 28 centimeters from the medial malleolus. Morrissey cough impulse, no impulse was felt. There is no inguinal lymphadenopathy. All arterial pulsations were present. The left lower limb is normal, and the ankle joint was with full range of motion. On auscultation, there was no bruit heard at the saphenofemoral junction on Morrissey's cough impulse, and there was no murmur over the varicosities. Abdominal examination, there is no palpable mass or organomegaly, no shifting dullness or fluid thrill. Hernial orifices are normal. A paramedian vertical scar mark was noted 10 centimeters on the right side of the lower limb, abdomen. Digital rectal examination and scrotal examination was normal. Other systems, respiratory system, cardiovascular system, and CNS was within normal limits. Summarizing, a 58-year-old male hotel worker with no known comorbidities presented with complaints of dilated tortuous veins over right lower limb for the past 20 years and hyperpigmentation of the right ankle and lower leg for the past 5 years and a healed ulcer over the right gaiters area. On examination, he was found to have varicosities in the right leg at the region of the GSV, below knee, hyperpigmentation and lipodermatosclerosis, and scar of a healed ulcer over the gaiters region with a positive Trendelenburg test 1 and 2, positive tourniquet test, and a negative modified Perthes test. Diagnosis is chronic venous insufficiency of the right lower limb of primary etiology involving the great saphenous vein with saphenofemoral and perforator incompetence and a history of a healed ulcer with no signs of deep vein thrombosis. CEAP classification is right, C5, EP, ASP, and PR.
That's a very good presentation.
Thank you.
And
Thank you.
What is the relevance of asking age, gender, and occupation in your case, in a case of varicose?
Varicose veins incident tend to increase as the age increases in a patient.
What about gender?
Why it increases in age?
One is the age-related degeneration and the loss of the venous tone. There is venous dilatation also. And in this patient, because it's a male patient, usually it is in females that varicose veins is becoming a risk factor because of the hormonal effects, which is not relevant in this patient.
And in older age, SFJ become incompetent also. That is also a point. Okay, then why you are asking about gender? What is the importance of gender? Is there any relevance?
Varicose
Veins are more common in female gender.
Why it is more common in females?
Due to the hormonal changes, especially estrogen and progesterone. If patient is a multiparous woman, then progesterone, which relaxes the uterine smooth muscle, also causes relaxations of the smooth muscles of the venous walls, which causes dilated veins. Also, gravid uterus compresses the IVC according to the parity of the patient. With regardation to menstrual cycle, the imbalance between the estrogen and progesterone ratio immediately during the onset of menstruation also causes softening of the collagen fibers in the vein wall.
Okay,
which predisposes the females to varicose veins.
Okay, and the importance of occupation?
This patient is a hotel worker, which means he has prolonged hours of standing. So that is found to be a risk factor for developing varicose veins.
Okay. And your patient has got hyperpigmentation of the leg. What are other skin changes you are expecting in this case?
Eczema, itching, edema. In complications of varicose veins, you can have ulcers. Then superficial thrombophlebitis can cause redness, erythema, tenderness. Then atrophic blanche, corona phlebitis, lipodermatosclerosis.
Okay. There can be also ulcerations also. You have mentioned venous ulcer.
Yes. Healed ulcer.
Okay. What are the characteristics of a venous ulcer?
A venous ulcer is usually superficial, above the deep fascia, has granulation as a floor, has margins which are
Sloping
edges and well-defined margins. And also, there can be induration surrounding it because of the chronic venous insufficiency, and it is usually painless. And the discharges can be profuse due to the lymphoria.
So oval in shape and site most common in the gators area.
There can be unhealthy pale granulation tissues also.
Yeah, on long stand.
Prolonged, yes. Okay. You have mentioned that there is no bursting pain in the leg. Why you have asked on that question?
To roll out the DVT, deep vein thrombus.
DVT. Okay. How can you differentiate if it is a venous, if there is pain, how can you differentiate is a venous claudication or arterial claudication pain?
On elevating the limb, if the pain is relieved, it is usually venous in origin. But if it is aggravated, it is arterial.
What is the type of pain that is differentiating from venous and arterial?
Venous, it is bursting, dull-aching type of pain, but in arterial, it is a cramping type of pain.
Cramping type of pain. Okay. Then, is this patient having night cramps?
No night cramps.
If there is night cramps, what can be the reason? If the patient is experiencing night cramps, what can be the reason?
Arterial disease can be present in this patient.
Apart from that, one more. That inflammatory change, there will be skin changes also. We know vasomotor changes will also be there. That can also cause us night cramps.
Because of the accumulation of the this waste products, and the patient will be having night cramps, and also because of the internal abnormalities also, she can develop night cramps also in a varicose vein patient.
Okay, can you just mention the great saphenous vein and small saphenous vein course? Difference, formation and course. Difference.
GSV originates from the medial marginal vein, ascends just in front of the medial malleolus, and it goes in the medially till the knee. At the knee, it takes angulation and goes to little posteriorly and ascends posterior, posteromedially in thigh, and it enters the saphenofemoral junction, which is 4 centimeter below and lateral to the pubic tubercle.
Yes, ascending behind the medial malleolus, not in front.
Actually, no. It's actually in front. Saphenofemoral junction is actually 2.5 centimeter below and lateral.
It's variable in text. Different textbooks.
Yes. Then small saphenous vein.
SSV course.
It originates from the lateral border of the dorsal venous arch.
Yes.
Goes behind the lateral malleolus, ascends in the posterior part of the leg and cuff, and it enters into the saphenopopliteal junction, which is a highly variable one.
Highly variable. Okay. Can you mention some small saphenous vein variations?
One is the Giacometti vein, which is the anterior caudal extension of the short saphenous vein. It can either be just an extension, or without joining into the saphenopopliteal junction, it can go directly and join into the
cranial extension.
Cranial extension of short saphenous vein into the deep venous system, or either by Giacometti vein, it can directly terminate in the great saphenous vein.
Yes.
Then also SPJ can even be as low as mid calf at times.
It is highly variable.
Okay.
Yes, it is very highly variable. It is also.
Okay. Can you elaborate on a modified Perthes test? And what is the interference? Modified
Perthes test is done to assess the patency of the deep veins, mainly to rule out a DVT. In a modified Perthes test, we tie a tourniquet on the saphenofemoral junction, and we ask the patient to, in the standing position, and we ask the patient to walk or exercise for 3 minutes. And the appearance of varicosities and patient complaining of a bursting type of pain is indicating of a non-patent deep venous system due to DVT.
Okay. There will not be collapse of vein, superficial veins also if there is Okay. Good.
Based upon your clinical history and examination, what is the patient's varicose vein etiologically?
So primary etiology, no.
It's a primary etiology.
He has a risk factor for long-standing worker. He is a hotel worker who has a history of long-standing.
So what is the difference between? It is insidious onset. If the patient had an insidious onset, and also it had a history of long-standing. He's a hotel worker, and there is no history of DVT also, which is most likely to be primary varicose vein. So what is the difference between a primary varicose vein and a secondary varicose vein?
Secondary vein has a definite cause behind it. Usually, secondary venous occurs post thrombotic limb. That is in a DVT after on the treatment. Once the vein recanalizes, the perforator valves get destroyed, and it usually presents as isolated valve incompetence. This is a secondary DVT. Also, secondary cause of DVT can be due to pelvic pathologies, as mass is compressing the IVC. And for example, pelvic tumors, irradiation, retroperitoneal fibrosis, and also rarely May-Turner syndrome can also present in left side.
Really, the primary varicose vein, the pathology lies in the venous system. There will be incompetent venous valve, cuspis, and everything. But in secondary varicose vein, in the initial pathology lies in the deep venous system.
Deep vein system.
Yes.
They're different. So, what is the fundamental hemodynamic pathology behind the formation of varicose vein? What is the fundamental
ambulatory venous hypertension?
What are the factors? What are the factors responsible for ambulatory venous hypertension?
The factors working against or responsible?
Factors responsible.
So the negative intrathoracic pressure during inspiration sucks the blood from the deep veins, and also the calf muscle pump, which calf and foot muscle pump, which pushes the blood against the gravity, or the factors,
and the vein wall,
and the presence of vein valves, which facilitate the unilateral flow of blood.
All of this
can be divided into pressure gradient dysfunction or because of the valvular dysfunction. Pressure gradient dysfunction occurs because of the increased intrathoracic or abdominal pressure, or because of the calf muscle pump dysfunction. The valvular incompetent, valvular occlusion, venous occlusion, compression, because as in May-Turner syndrome, all predispose to valvular dysfunction. So, coming to the next question, what is a morphological progression of superficial varicose veins as a result of ambulatory venous hypertension? What is the morphological progression?
First, it presents as telangiectasias, reticular veins in early stage. Then slowly starts as varicose veins, and then slowly complications sets in. Starts as edema, eczema, pigmentation, and inevitably it will come into an ulcer in the gaiters area. It also associated with skin changes like lipodermatosclerosis.
Initially, there will be telangiectasia, which is intradermal dilatation of venules less than 1 millimeter. Later on, there will be reticular veins, which is subdermal dilatation of venules 1 to 3 millimeter. Later on, there will be varicose veins, which is more than 3 millimeter. Subcutaneous dilatation of varicose veins. Later on, there will be coronal phlebiectasia. What do you mean by coronal phlebiectasia?
Coronal phlebiectasia are fan-like reticular veins in the ankle joint, which is actually coming under C4C, which is a manifestation of an advanced disease.
So it's also malleolar flare, reticular veins in and around the malleolus, which causes a sign of advanced venous disease.
Advanced, yes.
We are halfway through the mark.
What do you mean by lipodermatosclerosis? Halfway. What do you mean by lipodermatosclerosis? What is the pathology behind it?
Lipodermatosclerosis refers to thickening of the skin and fibrosis, and the pigmentation occurs because of the deposition of hemosiderin and melanin.
What is can you give some differential diagnosis for lipodermatosclerosis?
It can be eczema.
It can have because of a pretibal mixed edema, there will be myxopathy, and it can be morphine of scleroderma. It can be because of necrobiosis diabetic or as in a diabetic patient. Could be any differential. So, what do you mean by atrophy blanche? What is its pathology?
Atrophy blanche is just a whitish pale hue seen over the healed ulcer area. It might be recurrent chronic scarring.
It's mainly because of the underlying capillary occlusion causing dermal necrosis, which is resulting in atrophy blanche. So, what is the pathophysiological mechanism for venous ulcer formation in your patient?
Yes, there are many theories. The few theories are the fibrin cuff theory and mind cell entrapment theory. In the fibrin cuff theory, due to the venous stasis, blood pools into the venous system, and then there will be pericapillary infiltrates, which are causing a form fibrin cuff. And this will cause impaired oxygen as well as nutrient transport into the dermis and the subcutaneous tissue, eventually leading into an ulcer formation. Then there is the white cell entrapment. Here, it is said that there are
They seem to be lost their connectivity. They'll come back.
So we are losing time.
We'll give compensation. Hmm.
Hello?
Hello, sir.
Sir, can you hear us?
Sorry, sir.
Yeah, it's okay.
Sorry.
We'll give compensation. Don't worry.
So coming to the next question, what do you mean by Safina varies?
Safina varies is the dilatation at the SFJ junction. SFJ.
It's a
Proximal part of
It's a
GSV.
GSV.
it's a sacrodilatation of the base saphenous vein near the sacrofemoral junction. So what is his most important differential diagnosis?
A femoral
Femoral hernia.
How will you differentiate from a femoral hernia?
It on elevation, the Safina varix will go away, but femoral hernia might not.
Yes,
No, actually, Safina varis is usually compressible and it usually fills from below downwards, whereas femoral hernia usually extends from above downwards. And it will be having a bluish tinge also.
Yes.
Okay. Now coming to the management part. So what investigation? What is the gold standard investigation for varicose vein?
Only one investigation we were to do, which is a duplex imaging of the bilateral lower limbs.
Okay. What is the frequency of the probe that is used in the duplex scan?
7.5 to 15 megahertz linear probe is commonly used.
What is the color setting?
The Doppler setting, there red will indicate retrograde flow and blue will indicate flow towards in the anterograde direction towards the heart.
Okay, good. What is the difference between the Doppler and the duplex scan?
In duplex scan, we are combining a B mode ultrasound along with the Doppler. While in Doppler, it is only the
We can see the two-dimensional image of the vein in addition to the Doppler stuff.
Now, what is the extra advantage that you get by using the duplex scan over the Doppler one?
We can ideally see the vein. We can see the reflex and grade the reflex.
No. Actually, in Doppler,
we can assess the anatomical extent of the disease.
Exact location of the perforators.
No, actually, in Doppler, we can see about the reflex, the rate of the flow, the velocity of the blood flow. In duplex, also, we can assess all these things. But in duplex, we can also assess the anatomy of the vein, whether it is fit for the any surgery. That is in detail, the extent of the varicosity.
Extent of the disease.
We can extend the reflex.
Okay. So in a Doppler report, what specific criteria that you look for that defines an incompetent perforator that may require that warrants a surgical intervention? What is that specific criteria?
Perforator of size more than 3.5 millimeter with a reflex more than 350 milliseconds.
Or more than 0.5, more than 0.5 seconds.
Sorry, for perforator, it is 350.
So
500 milliseconds is for axial veins.
So what is pathological reflex?
A reflex lasting more than 500 milliseconds in axial veins and more than 350 milliseconds in perforator veins and more than 1 second in deep veins is called pathological reflex.
Okay. So, so in a venous ulcer patient, so you are going to suggest a compressive stocking, like a 4-layer compression bandage. So what is a specific prerequisite that you would look for before you are giving that compression bandage?
ABPI.
ABPI less than 0.5 is a contraindication for compression bandage.
And what will be the pressure difference then?
If ever we are giving, it will be lower.
Patients having ABPI of
We only suggest compression bandage for patients with ABPI less than 0.5.
Because actually the ulcer is mixed, not just venous.
Okay. Can you just can you just tell the British classification for the compression stocking pressure?
Yes. Grade 1 is 14 to 17. Grade 2 is 18 to 25. And grade 3 is 25 to 35.
Okay, good. So can you give me what is the gold standard treatment for varicose vein surgery currently?
At present, endovenous endothermal ablation can be either radiofrequency ablation or endovenous laser ablation of the thigh segment of GSV.
Okay. Can you tell me the contents of the tumescent anesthesia?
It's used for
Yes. We can 300 to 500 ml of cold normal saline or even ringer lactate solution can be given. We also include lignocaine, sodium bicarbonate, adrenaline. Lignocaine, adrenaline complication.
There is also mixtures where we can use in addition to this dexamethasone or dexmedetomidine.
Yes.
Okay.
Bupivacaine can also be used.
Sodium
Lignocaine is
bicarbonate can be.
Okay. What is the advantage of using this?
Tumescent
The
anesthesia.
tumescent is acting primarily as a heat fan, so that when we're giving thermal energy either by RFA or EVLE, the surrounding structures are being protected. There is the added advantage of also providing a hydro dissection plane for better delineation. And importantly, it is compressing the vein against the prop that we're using so that the effect.
Importantly, it also provides analgesia also.
So why foam sclerotherapy? Why foam sclerotherapy is superior to the liquid sclerotherapy?
Again, their connectivity.
Minimal amount of foam, we can cover a max.
Hello?
Hello, sir. Can you hear us, sir?
Yes, yes, there was a drop for about 20
Can you hear us, sir?
seconds.
Hello, sir.
Sir, can you hear us, sir?
Yeah.
Sorry, sir.
Sorry, sir.
Sorry, sir.
Hello. Why is foam?
Yes, foam
Can you answer
sclerotherapy
that question?
above, yes, used because with minimal amount of the sclerosant, we can cover a large area, because using foam, you're increasing the total surface area. So with a small foam can have a large contact surface.
No, the actual thing is the foam. When we use the foam, it displaces the blood. So it will not mix with blood. So it will come direct contact with the endothelium, causing sclerosis.
What is the most common complication?
What is the most common complication after sclerotherapy? Cosmetic.
Extravasation can cause pigmentation of the skin,
Necrosis,
eczema.
inadvertent entering into the deep vein system.
So, do you know the term EHIT?
Yes, endovenous heat-induced thrombus. Just has
So how
4
can we
grades.
prevent? Okay, 10.
4 grades, where grade 1 is a thrombus at the saphenofemoral junction. A grade 2 is a thrombus in the deep vein, which is less than 50% occlusion of the lumen. Grade 3 is where there is more than 50% occlusion, and grade 4 is.
Okay, how can we prevent it?
One is we fire 1 centimeter distal to the junction, so that we do not crossfire into the deep vein.
Okay, it should
But
be ideally.
also current studies is we can do laser crossectomy, where we can fire flush with the junction of the SFJ with the minimal in a highly experienced surgeons. There is very less chance for e-hit.
So, okay, one more question. In GSP stripping, can you name the stripper name that we are using?
Mayo stripper.
Osseous strippers, and
Which is an inverting stripper.
the ideal way is penetrate and invagine it.
What are the other non-thermal, non-tubulent methods for
Mechanochemical ablation, cyanoacrylate adhesive closure, and polydocanol endovenous microfoam.
Okay. What is the most common complication after standard varicose surgery and a recurrent varicose surgery?
After standard varicose surgery, more common complication is injury to the saphenous nerve.
There can be hematoma at the surgical site.
It is wound infection. If it is standard, wound infection is more common. If it's a recurrent one, there will be lymph leak, and also wound infection can be there. What are the complications?
Last 2 minutes. Last 2 minutes.
What are the complications of varicose veins?
So first, edema, bleeding, pigmentation, venous deformity, atrophia blanche, lipodermatosclerosis, varicose ulcers, periosteosis, and actually superficial thrombophlebitis.
You mentioned your patient was having an ulcer. It is healed now. What if your patient's ulcer that bleeds on touch with an inverted edge and then foul smelling? What will be your primary differential?
Now, will you confirm?
The malignancy in this patient.
Marginal ulcers.
Okay. Then how will you confirm the case then?
Do an biopsy for this patient.
Okay. What is post-thrombotic syndrome? And what is the triad of it?
Post-thrombotic system, post-DVT development of varicose veins. Post-DVT is called post-thrombotic limb bend.
What is the triad of it? There will be pain. There will be edema, there will be pain, and also there will be skin changes will be there. Lipodermatosclerosis. If the patient presents with a post-thrombotic ulcer, will you go for EVLA or will you go for stripping of the veins?
First of all, if it's post-thrombotic,
We will be
if any intervention is done, we have to ensure that the deep venous system is patent. Complete occlusion in the deep venous system is a contraindication for any endovenous procedure that we're going to do. In case of that, in this patient, we can go for EVLA.
No,
We cannot actually do EVLA and even stripping of the veins. Both are contraindicated.
That's why we confirm the patency of the deep vein.
First, we confirm.
Actually,
the patient post
Your last question. Your last
Having a
question.
thrombotic, that means it's a DVT case.
Suppose this patient comes to a casualty with a bleeding blowout, and the duty emergency medical physician puts a tourniquet over the bleeding site and calls you for surgical intervention. What will you do?
No surgical intervention, emergency in the casualty setting we will be doing. We will be just advising compression.
No, the patient came with a tourniquet over the limb.
Bleeding over the limb, and the emergency physician put a tourniquet, and you need to remove the tourniquet immediately because it will be compromising the arterial flow also. So immediately remove the tourniquet and ask the patient to elevate the limb. It will subside on its own. Yes.
Thank you. Thank you very much. Thank you very much. Both the teams have done a good job. Now it's over to the examiners. We call upon Dr. Robinson.
Thank you, sir.
Thank you, sir. Thank you. Thanks.
Dr. Robin, for your comments.
Good evening, sir. Good evening, sir.
Good evening.
A good performance by both the teams. I think this is just my personal view. I think they've asked all the questions. Team Kottayam seems to have been dominated by few PGs. I feel more. I think we want equal participation from all PGs, not just one person, and one person interferes with the other questioning and answering. Yeah, that wouldn't be fair. But otherwise, yes, sir, I think they have covered the whole topic per se, both the teams, yes.
Thank you, Dr. Robin.
Thank you, sir.
Dr. Vijay Paul.
Good evening, sir. Actually, both the teams have actually performed very well, and it's very difficult to judge between the two. And I probably agree with what Robinson said then about the equal participation. But in general, I think both the teams did very well. I think we're going to have a tough time.
Yes.
Thank you. Thank you, Dr. Raju. Anything from your side, Dr. Raju? You're muted.
Good evening, sir. Actually, both the teams have done very well, but I thought as teachers, they should, if it is judgment as teachers, they should be a little more on the teaching side rather than just probing them. The questions were a little more something like kind of pointing them out rather than kind of getting answers out of them many times. Both the teams. It was more like a competitive event, I would say. I would have thought for varicose veins, for example, we could have discussed a little about conservation or about medical line of management, things like that, which both teams don't seem to have been bothered about. They're more bothered about the very high-end treatment modalities and the complications and things like that. But overall, it was good. I was very in the hernia part of it. The GMC team was actually appreciative of the Sri Gokulam team's answers, and they tried to push them up. But the reverse sometimes is a little less. But overall, both teams have done very well. Both are very knowledgeable teams and both highly competitive teams. Very difficult to say between the two teams, I would say.
Thank you very much. Now we go to the next pair of teams. GMC Trichy.
Thank you, sir.
Thank you. And GMC Trichy versus Loops Cochin. Can both the teams come online? GMC Trichy? Yeah. Okay, fine. So GMC Trichy can make the first presentation. We can share the slides. Okay, go to the slideshow mode.
Yes, sir.
Your
Can it
time
start?
starts now. Yeah, please.
Good evening, everyone. We are from Medical College Thrissur. Myself, Dr. Ria Thomas.
Dr. Ashik.
Myself, Dr. Karan Tommy.
Myself, Dr. Sri Parvati.
Mentored by Dr. Haridas TV. We are presenting a 48-year-old male who's a manual laborer residing from Thrissur. Came with chief complaints of pain abdomen for past 2 years, vomiting for the past 2 months. He was apparently well 2 years ago when he started having occasional pain in the upper abdomen, which was insidious in onset, burning type of pain, which was followed by prolonged periods of fasting, especially during early periods of mornings, usually lasts for a few hours and relieved partially with food intake and antacids. There is no history of radiation. It was associated with sour taste in the mouth. These symptoms usually lasted 2 to 3 months that subsided with your medication use and recurred after every few months. For the past 2 months, the patient started experiencing occasional copious vomiting following heavy meals. Vomiting occurred towards evening hours. It was projectile, non-bilious in nature, contained partially digested food particles that were associated with putrefied smell. Frequency of vomiting increased 1 month, that is 2 to 3 times per day, which was not blood stained. He often experienced a ball rolling movement in the upper abdomen following food intake, which subsides after vomiting for the past 2 months. There is no history of jaundice, no history of blood in stools. He has normal appetite. There is no history of early satiety. There is history of loss of weight, which he is not able to quantify. On history, no history of breathlessness or hemoptysis, no history of bone pain. There is no history of headache or altered sensorium. Coming to the past history, there is no history of diabetes mellitus, hypertension, or any other comorbidities. There is history of occasional pain medications and antacid use. There is no history of previous surgeries, no history of psychiatric illness, and there is no history of ingestion of caustic agents in the past. Coming to the personal history, he is married for 10 years. He takes a mixed diet. Appetite is preserved. Patient complains of constipation for the past 1 month. Sleep habits are within normal limits. There is history of alcohol binge drinking occasionally for more than 15 drinks per day, and history of tobacco smoking around 5 cigarettes per day for more than 10 years. Family history, there is no history of similar complaints in family. There is no history of malignancy in family members. Treatment history, he has been taking over-the-counter medications like antacids and is irregular on treatment.
On general examination, the patient was examined after informed consent in a billet room after adequate exposure. The patient is conscious, alert, and cooperative. Vitals, pulse rate is 96 per minute, regular rhythm and normal volume. BP was 116/20 mm of mercury. Respiratory rate 20 per minute. The patient was febrile. His tongue was dry and skin turgor was reduced. He was a thin-built patient with moderate nourishment and BMI was 18.4 kg per meter square. Pallor is present. There is no lymphadenopathy, no periodal edema. Performance status, Karnofsky score 80%. On inspection, the abdomen is covered with visible fullness in the upper abdomen. All quadrants move corresponding with the respiration. The umbilicus is central and normally inverted. No nodules or discoloration seen around the umbilicus. Visible gastric peristalsis is seen in the left upper abdomen, moving from left to right direction, from left lumbar to umbilicus to the right lumbar region. There is no visible intestinal peristalsis. There is no distended veins or visible pulsation. Hernial sides are free and external genitalia was normal. On palpation, there is no local rise of temperature. The abdomen is soft and non-tender or no garding. Fullness is palpable in the epigastrium and umbilicus. There is no discrete lump is palpable. Liver and spleen are not palpable. Hernial sites are free and there are no palpable lymph nodes. On percussion, impaired not heard in epigastrium and umbilicus. There was no shifting dullness. On auscultative percussion, greater curvature of stomach is delineated at the level of umbilicus extending to the left hypochondria. On auscultation, succussion splash was heard. Normal peristaltic sound heard in left of the abdomen. On digital rectal examination, normal inner tone, stool stain plus, there is no blood stain or there was no melena. Examination of spine and back were normal. Examination of left supraclavicular area and left axilla, there was no significant lymphadenopathy noted. On systemic examination, cardiovascular system, respiratory system, and central nervous system were normal.
So summary, the 48-year-age male presented with recurrent episodes of mid-upper abdomen pain for past 2 years, which were more during fasting hours and relieved with food intake and antacids. With the periodic remissions were present. He complains of projectile non-bilious vomiting for past 1 month, containing partially digested food particle with the pungent putrescent smell, also associated with the ball rolling movement, which subsided with the vomiting. On examination, distended stomach noted with the features of outlet obstruction. Other systemic examinations were within normal limit. So our provisional diagnosis is a case of gastric outlet obstruction, probably due to benign etiology, a case of cicatrizing duodenal ulcer. Thank you.
Thank you. It was a good presentation. How will you derive it to diagnosis from your history? Can you please tell us? Yes. In our case, the age group is early age group. There are features of duodenal ulcer like burning sensation during food intake and hunger pain.
Patients have long duration of pain as well as there will be a periodicities also there, and mostly the patient having the pain is remitted by means of taking the food, and there will be even the vomiting is occurs after before 2 months only, having the long lasting only.
And on examination wise also, we could not find the mass. So we would rule out a malignancy in this case, and probably case of benign absence of long duration.
Can I ask his What are the causes of projectile vomiting? Can you explain other causes of projectile vomiting?
In our case,
The projectile vomiting is mainly having any kind of intratomic. Okay, the projectile vomiting is mainly having if there is increase in the intracranial pressure, you have any traumatic brain injury, or like that. Sometimes the gastric outlet obstruction also.
Other diseases causing meningeal irritation, like meningitis, also can cause projectile vomiting.
There will be meningitis like features can also cause projectile.
In this case, there was no fever or there is no feature suggestive of any electricity, so we could rule out.
What is the color of vomiting that is usually expected in case of a gastric outlet obstruction?
Usually, it's non-bilious vomiting, partially
digested
food.
Yeah. Is there a possibility of occurrence of feculent vomitus in case of a gastric outlet obstruction? What should you consider the possibility as in that kind of patients?
Maybe in kind of any gastrointestinal fistula, we are not unaware.
Even though you have
gastrocolic fistula should be suspected in case of an advanced malignancy. There is a chance of gastrocolic fistula formation. In such patients, you should always suspect a gastrocolic fistula.
You guys mentioned there is no hemoptysis. Can you say conditions in which hemoptysis can occur in a gastric outlet obstruction?
Yeah, thinking in terms of any malignant gastric outlet obstruction, there will be chances of metastatic to lung lesions. There will be lung pathologies will result in breathlessness and hemoptysis. To rule out the metastatic symptoms, we ask the history.
Even if the patient having chronic duodenal ulcer on the posterior side, that there will be a chance of bleeding from the gastroduodenal artery that can also cause us like hemoptysis.
It's hematemesis.
Sorry, it's hematemesis.
And you have also given a history that patient is having recurrent episodes of vomiting. These kinds of patients can have malnourishment ears, which can also give blood in the vomitus, basically.
Okay, what is the concern you are having in this patient?
Yes.
If this patient is having persistent vomiting, what is the concern you are having in this patient?
Metabolic derangements,
Like
dehydration.
Yeah, and
there will be hyperchloremia, hyperkalemia, metabolic alkalosis will be there. Metabolic abnormalities will be present with the dehydration, signs of dehydration.
There will also be hyponatremia, hypokalemia, and also paradoxical aciduria in case of a long-standing. If the thing is not correct.
Hypocalcemia. So all electrolytes can be decreased. So in your case, you have presented a gastric outlet obstruction and it was due to a benign cause. What are the other causes of gastric outlet obstruction in total?
In total, we can divide it into benign causes or malignant causes. In benign causes, the first cause was like duodenal ulcer. It can be pyloric stenosis, or in psychiatric cases like gastric withdrawal, or chronic pancreatitis may cause. Then caustic injections. Coming to the malignant part, it can be CA stomach or malignancy in the duodenum, or any pancreatic head of pancreatic malignancies can also be. Or ectomegaly and lymphoma can also present.
Also, you can also add the congenital causes also. Because I asked in total, you can also add
Congenital hypertrophic pyloric stenosis.
Or rarely adult hyperpyloric also. Rarely.
You have said that patient is having burning type of pain. Is there any relation to food and pain in these kinds of patients with peptic ulcer disease?
If it's a case of gastric ulcer and we know the on food intake, the pain is relieved. While in duodenal ulcer, it's a case of pain is decreased. Pain is increased. Sorry, pain is increased. While in case of a duodenal ulcer,
Say
it
the
is a
location, probable location with relation to the pain and food intake. If it is within half an hour of the pain, food intake, it is usually a high gastric ulcer. If it is within 1.5 hour, it is usually a low gastric ulcer. If it is after 2.5 hours, it's a duodenal ulcer. And if it is the pain is persisting, and if it is increases with the food intake, it could probably be a malignancy.
in your examination, you have mentioned about BMI. And what are other signs of malnutrition that you'll be looking in your general examination?
Exactly. The patient may having some pallors, which will be there, and due to the hypoproteinemia, there will be generalized lymphadenopathy, which will edema, which can be there. Sometime like that. And when we are looking
the general
the skin,
examination,
there will be
general appearance of the patient can also
Usually
there will be loss of
Temporal
subcutaneous
muscle
fat.
wasting will be there.
Yes, temporal wasting
You
will be
should
there.
also look at mid-arm circumference.
Mid-arm circumference, you can look skin thickness, skin fold thickness.
Skin
You can
subcutaneous tissue will be less.
and yes, and also this patient has electrolyte abnormality. So and micronutrient deficiency like vitamin deficiency, chelosis, stomatitis, all such things you can look at the patient.
So in your inspection, you told that there is visible peristalsis. How do you look for peristalsis in this patient?
We make the patient to lie down, and we look tangentially to look for from the level of the foot to look for the peristalsis. We ask the patient to take deep inspiration and expiration. On while expiration, we look for peristalsis. And usually in our case, it will be usually.
Excuse me. You should stand by the side of the
patient.
Yes,
side of the patient. Tangentially look. And in our case, visible gastric peristalsis was from left to right, which is suggested more of gastric peristalsis. And other causes of peristalsis also can be there, like in small bowel cases, we can see central step ladder peristalsis, then left colonic mass, right to left peristalsis can also be seen. But in our case, it was left to right, so we favor in case of gastric.
Can you explain how to do succession flush?
Did you get a succession flush positive in this patient?
Yes.
Ask the patient to.
We will make the patient lie down, and we will place the stethoscope directly over the epigastrium, and we'll shake the patient. Keeping in the pelvis, we'll shake the patient. We can hear some gurgling sound that's suggestive of succession splash.
Actually, the prerequisite is patient should be NPO for 3 hours. For 3 to 6 hours, or if you are doing immediately, then at least patient should be filled with fluids prior to doing.
We have the succession flush.
You have to fix the stethoscope with your thumb and shake side by side the patient with the fingers, placing the lower side of the ribcage.
Okay. Let's take a scenario. You are residing in a remote area where there are no modern equipment available, and you have only clinical examination and some bedside tests to diagnose a gastric outlet obstruction. So, how will you derive the diagnosis? Just based upon clinical examination, some bedside tests.
We may have to start from the history, or you need the clinical examination, right? Okay. We can start from the history. On clinical examination, we may have to take some fetoscope like features. We can put over the region of epigastrium. We can hear the second splash, and can we do the ascolto percussion by using fetoscope with our percussion fingers. And
visible gastric peristalsis can also be seen.
Gastric peristalsis can be tangentially when we are looking.
Okay. Also, we can instill. We can give via RT. We can give 100 ml of normal saline.
Yes.
Saline test we can. Saline loading test we can run. And we will. Saline test we can.
On the inspection, usually the abdomen will be distended and there will be a left hypochondrial fullness that should not be missed in case of a.
In your examination, you have mentioned scaphoid abdomen. What does scaphoid abdomen mean?
Answering the ill nutrition, malnourishment of the patient.
No, the upper part and the
lower
examination, we saw a scaphoid abdomen. What is it?
The umbilicus central and the upper and lower part of the abdomen was also on the same level.
It's usually upper concavity. That is one of what you see it in congenital diaphragmatic hernia. No? In children, scaphoid abdomen means one of the DD is congenital diaphragmatic hernia. So it's usually upper concavity. So in upper concavity, you've told you have got epigastric fullness also. Those are a bit contradictory. So it's better to put.
You said that your diagnosis is a gastric outlet obstruction. What are the other causes of gastric outlet obstruction?
As I mentioned earlier, it could be benign or malignant. In our case, we are favoring more benign. That's duodenal obstruction.
What is your how do you manage your case?
Okay. Investigation wise, we will start with initial investigation. Routine blood work will be done to look for any anemia. Albumin, LFT will be done to look for any albumin loss, and renal parameters all will be assessed. Also, we will check for any CRP, PSA to assess the inflammatory status of the patient. Then we will proceed with the imaging investigation. First line of investigation will always be USG abdomen to look for any other mass, abdominal masses causing distal obstruction. With that, and proceeding further, we will go for only after stabilizing the patient, after dealing with all this dehydration and metabolic abnormality, we will proceed with kind of endoscopic procedures. We will proceed with the esophagoduodenoscopy we will be doing, and we will visualize the lesion and we will look for any ulcerations or not. So if there are ulcerations, we will take for biopsy and look for biopsy confirmation of benign or malignant conditions we will do. Further, proceeding with further.
Let's stop here. What are all the usual things that you're looking at an upper GI endoscopy, OGD-scopy basically?
Starting from the esophagus itself, we have to look for any kind of esophagitis or any gastroesophageal reflux. Erosive esophagitis there. Then look for any from the gastric and from apparatus everywhere. Is there any ulcer or any lesion we should have to look for? And we have to look for the pyloric region, externally stenosis there, and we may have to go for duodenum, and we will come back. And is there any reflux is there, and we have to look for the reflux
cardiac
of
region in esophagus. How do you look at the cardiac and fundus region in esophagus?
By doing JML will be done for the cardiac.
We are halfway through the mark.
And you should never miss pre-pyloric and post-pyloric regions. You should examine them thoroughly also while doing an upper GI. You have done an upper GI endoscopy and you have done a biopsy in this patient, and the biopsy came to be negative, and you are still on the high suspicion of malignancy. How do you proceed in this patient?
We will go for high imaging investigation like CEC to abdomen, CEC to thorax, abdomen, and pelvis.
You can always repeat a second biopsy, go deeper and into the deeper
Well
plane, and you can
biopsy
do a
can be
biopsy.
taken.
Biopsy can be taken.
If there is a failed edge biopsy, we can go for well biopsy to look for any infiltration, base infiltration, and
Meanwhile, we can also plan for the contrast scans.
Let's say that you have got positive for malignancy. Is there any role of endoscopic ultrasound in this patient?
It's to look for the to stage the disease. T-staging can be done with endoscopic ultrasound.
Also to look for lymph nodes.
To look for lymph
nodes. And you can take an FNAC. Yeah, you can also take an FNAC. EUS guided FNAC can also do.
Yes, exactly.
Okay. Your diagnosis is a benign disease causing from the stricture.
What is your surgical management in this case?
So after initial
Yes.
Okay, considering the benign etiology and the young age, we can initially go for endoscopy guided balloon dilatation can be attempted initially. Endoscopy balloon dilatation can be means like you are asking about the surgical management, no? There are medical management also. Medical management, we can give PPIs, H. pylori eradication protocols that can be done. Considering the surgical management, endoscopy balloon dilatation is there. We can dilate, guided dilatation can be done from 8 millimeter to 10 millimeter, 12 millimeter. Like we dilate the stenoxed part. So there is high chance for a recurrence in endoscopic balloon dilatation. So there is the refractory stenosis and recurrent stenosis. We can proceed with the surgical management like truncal vagotomy plus gastrojejunostomy, like bypass procedure we can do. Surgical management can be done.
What are the types of vagotomy that you know?
Truncal vagotomy, selective vagotomy, and highly selective vagotomy. In truncal vagotomy, we are taking off main trunk and come to the selective vagotomy from first to second division. We are avoiding. Then we are taking the motor division. We are we are avoiding only the secretory region. We are taking. No, we are taking the
is usually described as Truncal vagotomy is usually described as vagotomy done above the celiac axis, and highly selective vagotomy is below the celiac axis.
Celiac axis.
And then highly selective
How do you do
vagotomy,
a
are taking
highly selective vagotomy?
We will
How to
preserve
do
the
a highly
nerve.
selective?
In highly selective vagotomy, we will preserve the nerve of Ladharchit and crowfoot, supplying the pylorus part so as to prevent the motor function. So there won't be any complaints of gastric emptying, and we need not proceed with any bypass procedure. If there is higher occurrence with the high selective
Is there any
vagotomy,
border range which what are all the nerves to be resected? Is there any range?
We will have to
5 centimeter above the pylorus. Yes.
Usually
Is
7
from
centimeters
7
above the pylorus and 5
centimeters
centimeters from the gastroesophageal junction. And you should never miss the criminal nerve of Grassi. It
Criminal
is the
nerve of
most common
Grassi.
cause of recurrence, so it should
Recurrent
always
ulcer.
be. Okay, you said that you have done a gastrojejunostomy as a drainage procedure. So, what are the ideal characteristics of gastrojejunostomy? How do you do an ideal gas?
In case of a peptic ulcer, duodenal ulcer with outlet obstruction, we will proceed with the retrocolic isoperistaltic gastrojejunostomy. Row and by gastrojejunostomy, we will prefer. We will enhance the gravity dependent drainage will be much more better if we do retrocolic and isoperistaltic. We will anastomose the posterior wall of stomach, so there will be more emptying will be there. There won't be much delayed emptying.
Do you do vagotomy in all cases?
Just always not.
we may have to, can
What are
also
the
plan with
indications of vagotomy basically?
if the patient's having recurrent ulcers and it can be leading to the gastric outlet obstruction like complication, we may have to further initially we can start with the treatment of medical management and proton pump inhibitors.
If it's an intractable duodenal
The
ulcer, we
vagotomy
can
is limited only to complicated peptic ulcer disease, wherein there is
intractable
a recurrent ulcers
Failed
where the ulcers are not treated with
recurrence.
and a perforation or a recurrent bleeding. Only in those cases there is a.
You have done a gastrojejunostomy and postoperatively you have an anastomotic leak. What is the most common site of anastomotic leak in such cases when you do a gastrojejunostomy? Anastomotic site is the most
GJ.
GJ site.
Anastomy, sometimes
Actually,
people will
in
not
the angle
have.
of sorrow, you can tell.
Site of anastomotic leak.
And it's usually the angle of sorrow, that is the near the lesser curvature area. Okay. After gastrectomy, it's usually in the area of the lesser curvature.
If your diagnosis came, let's say that there is an alternate diagnosis that you have come to a gastric carcinoma, how do you proceed in this patient if it is a gastric malignancy causing gastric outlet obstruction?
Basic investigations.
Since it's a case of gastric outlet obstruction,
Finished with the investigation.
Your history biopsy came as a gastric carcinoma. How are you going to
And you
proceed?
have staged the disease, it's a resectable tumor. How are you proceeding for?
So we have to assess the T staging of the disease. If it's a tumor in situ or a T1D disease, we can proceed with endoscopy surgery. It's less than 2 centimeter and all. We can go with endoscopic mucosal resection or endoscopic submucosal dissection can be done. If it is a deep T1B or T2 lesions, we can proceed with, if it is resectable, we can proceed with the surgery or a neoadjuvant chemotherapy. Also, while doing biopsy, we have to look for the IHC markers for MSI, microsatellite instability, MMR protein, PDL also we can process. If they are positive, we can also plan for immunotherapy like pembrolizumab can be done. Considering the initial stages.
What is the ideal surgical strategy for a tumor causing gastric outlet obstruction?
You have to go for R0 reduction with
D2
gastrectomy.
gastrectomy with R0.
Mostly with
What are all the components that are removed
In D2 resection?
in D2 resection with radical gastrectomy?
1 to 12 nodes minus 10th node will be saved.
The distal gastric and pancreas we have to do.
Sorry.
We have to remove the distal gastric region as well as tail of pancreas and 1 to 11 10.
Splenic hilum spared.
Usually, in case of a radical gastrectomy with a D2 resection, 75% of the stomach, along with greater omentum, lesser omentum. Usually, tail of pancreas is not removed unless and until there is an infiltration. And usually, spleen is also not removed. And D2 goes till 12A. Till the 12A station, it is usually.
If it is
a if this case is a lymphoma, how will you manage a lymphoma?
Medical management like
we have to look for it's a primary or secondary. Mostly the diffuse large beta cell lymphoma is causing the gastric lymphoma. We are mainly treated as in the form of medical management like archop regimen, rituximab, and
So remember, the
cyclophosphamide.
patient is having gastric outlet obstruction. It's a lymphoma causing gastric outlet obstruction. So that part also should be covered.
Yes.
So in lymphoma causing gastric outlet obstruction, you should always consider the surgical strategies because it's already causing a symptoms. The indications for gastric lymphoma surgeries itself complications which are bleeding, perforation, and obstruction. Let's say that you have diagnosed it as a cyst. So how do you manage if it is a case of cyst?
Largest causing obstruction.
With gastric outlet obstruction.
Mostly in gastric cyst, we have to go for surgical management like vertical resection. If we have to mostly.
Imatinib add-ons that we imatinib can also be done. And
do you do any trials for chemotherapy in gastric ulcer cases? Just name some trials.
Clot regimen, trifluorouracil, leucovorin, oxaliplatin, and
Trials.
Yeah,
also fluoropyrimidine based regimen, cyclophosphamide, oxaliplatin can be done along with the radiation. Chemo radiation can be done for advanced stage.
You have done gastrectomy. Are there any post-gastrectomy complications that are to be expected?
You have just 2 minutes left over.
Mostly, post-gastric complication is starting from the infection, hemorrhage manifestation. Bleeding is the most immediate bleeding,
and there will be anastomotic
leak which can be expected from the complication, and some other complications which can be expected.
Dumping
syndromes like there will be deficiency of iron deficiency and vitamin B12 deficiency on the later condition, and mostly we have to manage dumping syndrome as a late complication.
In the POD4, you can expect duodenal stem blood also.
Yes, POD4.
Basically divide them into early and late complications.
Late complication. In early, it comes anastomotic leak, hemorrhage, and duodenal stem blood. In late complications, you have your nutritional deficiencies and vitamin B12 deficiency. Yeah.
Then afferent
loop syndrome, short stomach syndrome, etc.
All that should be mentioned.
You have said that your diagnosis is probably a benign secondary to stricture and duodenal ulcer. Is there any role of pyloroplasty? Can you describe any types of pyloroplasty?
Intractable large duodenal ulcer, pyloroplasty will be difficult to. It's a difficult procedure.
Not preferred in our case, of course. Due to stricture
pyloroplasty is not advised.
Okay, that is right. What are the types of pyloroplasty you can do?
You can do. There will be Henke Miculus pyloroplasty will be there. There will be Finis pyloroplasty.
Jabulay
pyloroplasty.
After vagotomy, why do you want to do a drainage procedure?
That's why if we are doing truncal vagotomy, the motor supply to the pylorus will be lost. So there will be delayed gastric empty. To counteract that, we need bypass procedure like drainage, gastrojejunostomy has to be done.
If you are doing loop gastrojejunostomy, are there any complications that are to be expected?
Considering loop gastro, there will be high chance of biliary reflux will be there, biliary gastritis will be there. So in order to avoid that, it's always better to proceed with the Roux-en-Y gastrojejunostomy.
Let's say that you have already done a loop gastrojejunostomy for this patient, and patient is presenting with a chronic biliary reflux gastritis. How do you tackle this patient?
Can convert it into a Roux-en-Y loop, or we can also anastomose the jejunal into side. But I don't think we can convert into a
Roux-en-Y reconstruction is always better.
Better to convert.
Thank you. Yeah, the second team can make the presentation. Groups can make it.
Good evening, we are Team Luz, presenting the case of a 60-year gentleman coming from Ernakulam. He is a shopkeeper by profession, belongs to a middle class family. Presenting with the chief complaints of pain in lower limbs since 1 year, restoration of little toe since 1 month. History of present illness. The patient was apparently normal 1 year back. He started noticing pain in the left calf region, which was intermittent, cramping type during walking and relieved by taking rest. Initially, he had pain after walking for about 1 kilometer, but he was able to walk in spite of pain. After about 6 months, he started having pain even after walking about for 200 meters, beyond which he had to take rest to get relief. He also gives history of trauma to little toe 2 months back while walking, following which he developed a non-healing ulcer associated with pain, which was severe in intensity, continuous in nature, which disrupts his sleep and relieved by legs hanging down and medication. He noticed blackish discoloration over the left little toe 1 month back, which gradually progressed to present state. No history of pain, discoloration, or other limbs. In other limbs, fever, force milling discharge, localized swelling or redness, chest pain, breathlessness, no history of postprandial abdominal pain, loss of consciousness, blurring of vision, tingling, numbness in any limb. Past history, patient on case of type 2 diabetes mellitus since 10 years on metformin, dyslipidemia since 2 years on atorvastatin, now history of hypertension, CAD, asthma, CVA, TIA. He has treated at local hospital for toe wound with regular dressing and analgesics. No relevant surgical history. Personal history, he takes Mr. Diet, normal appetite, sleep disturbed, bowel and bladder habits normal, smoker for last 20 years, 5 cigarettes per year, 5 pack years, consumes alcohol occasionally. Family history, married, having 2 children, no history of similar disease in the family, no history of CAD or stroke in the family. Summary, this is a case of 6-year gentleman, is a smoker and diabetic, presented with the chief complaints of left leg pain since 1 year, black discoloration of left little toe since 1 month. There is also a history of progression of claudication distance and rest pain.
General physical examination. Patient was examined in a well-lit room after obtaining consent and adequate exposure. Patient is conscious, cooperative, well-oriented to time, place, and person. He is comfortable with legs hanging below the level of bed. No pallor, icterus, sinuses, clubbing, and generalized lymphadenopathy. Performance status, Kanosky 80, moderately built and nourished. BMI is 22.89. Vitals, blood pressure 130/90 mmHg in both arms in sitting position. Pulse rate was 96 per minute. Right radial artery, regular rhythm, no more volume and character, no radio delay, no radio femoral delay, no vessel wall thickening. Respiratory rate is 16 per minute and upper breath. Local examination, inspection of both lower limbs. Attitude of the both lower limbs are normal. Gait is normal. Left lower limb, blackish mummified fifth toe with clear line of demarcation at the level of middle phalanx, proximal to line of demarcation. No signs of inflammation. Loss of hair, subcutaneous fat noted from foot till calf. Skin is shiny and eyes are brittle and transverse ridges noted. Muscle wasting seen at calf level. Burger's angle circulatory insufficiency 20 degree. Capillary filling time prolonged greater than 20 seconds. Venous filling, veins are guttered and delayed refilling is noted. Thigh of affected limb appears normal, no stiff lesions or no engorged veins. Examination of right lower limb, no signs of ischemia noticed, no evidence of any ulcer or gangrene. Burger's test 60 degree. Capillary and venous filling are normal. Palpation, left lower limb. Left leg is cold compared to the right leg. Left fifth toe is hard and shriveled with no sensation, crepitus, and with clear line of demarcation. Tenderness and hyperextension noted the line of demarcation. Muscle wasting noted. In left leg, calf circumference is 29 centimeters comparing to the right side, which is 35 centimeters. Capillary refilling time delay. Harvest time greater than 1 second. Cross leg test oscillating movement of left leg noted. In palpation of pulses, in left lower limb, pulses are palpable up to the popliteal artery and it is absent on the distal arteries. In the right leg, it is all pulses are palpable but distal pulses are weak. Sensory system, absent sensation of a gangrenous area, hyperexcitation noted the line of demarcation, all other sensations intact. Motor system, tone, right lower limb and left lower limb, tone is normal across all joints. Power, right and left lower limb 4/5 across all major joints and reflexes are preserved. No evidence of superficial thrombophlebitis, movements of joints, fifth metatarsal joint, movement loss, rest of the joints are on full and free, no inguinal lymphadenopathy. Palpation of right lower limb, warm to touch, no tenderness present, no evidence of superficial thrombophlebitis, no inguinal lymphadenopathy. Examination of both upper limbs are normal. Auscultation, no bruit. Other system examination, CVS, respiratory, and the central nervous system are within normal limits. Abdomen soft, non-tender, no organomegaly or no not palpable. Summary: 60-year-old male, smoker, and diabetic, presented with chief complaints of left calf pain since 1 year, black discoloration of left little toe since 1 month. On examination, dry gangrene of left fifth toe with non-palpable dorsalis with ATA, PTA pulses with signs of ischemia. Burger's test is positive. Capillary and venous filling time is delayed. Diagnosis: chronic limb-threatening ischemia of left lower limb with dry gangrene of left little toe, probably infrapopliteal disease due to atherosclerosis. It was a good presentation.
So we'll start with why do you say it's a case of POAD?
It's a 60-year-old male. First of all, it's a 60-year-old male who is a chronic smoker. He's also having comorbidities like diabetes and dyslipidemia. And also, he's having claudication pain, which progressed to rest pain. On examination, pulses, left lower limb distal pulses are absent with gangrene of the fifth little toe. We can also see ischemic changes over the skin and the nails. Then there is delayed capillary filling time, venous filling time is increased, Burgess angle is less than.
So based on the history, how severe is the disease? Or can you tell me the progress of disease in case of POAD? How does the disease progress?
In this patient, in your patient.
In our patient, the claudication pain has increased from Boyd 1. You can classify it according to Boyd classification, where the patient had Boyd 1 first, where the patient can walk up to a distance and then continue walking, and then later it progressed to he had to take a rest for some time, and then later he had a rest pain.
Now, what's current status of the patient according to some Rutherford or Fontaine classification? What is the stage of your patient? Grade of the patient?
According to Fontaine, now the stage is class 4. Whereas according to Rutherford, now the stage is class 5.
Gangrene is also there, no? The little gangrene is there. So according to Rutherford, it will be 6. Gangrene will be considered 6. Oh, limit tragedy.
6 is major tissue, not an extensive gangrene.
Okay. In your history, you explain about the rest pain. Can you please explain what is rest pain? What is the features of rest pain?
Rest pain is mainly due to the this is affecting the nerves of vessels affecting the nerves. That is crying of dying nerves.
So what are the nerves affected? Can you explain what are the nerves affected in this? What are these crying nerves? Which nerves are
nerves?
The C fibers are mostly affected.
Plantar nerves will be mostly affected.
And C fibers.
So, if a patient is having severe POD but he does not have any pain, what will be the cause? He is having this kind of POD, severe POD. Any other causes?
Because he has diabetic, he might be having neuropathy.
Very good, very good.
What is claudication? What is claudication?
From the history.
From your history. It is a cramp-like pain. It starts as the patient starts walking, and it will get relieved as the patient will take a rest. The claudio means eye limb. It is due to the production of the substance P. Yes. Okay. Now, okay, good. How will you differentiate between arterial, venous, and neurogenic claudication?
In arterial claudication, usually we'll be having a claudication distance, and the patient's limb will be cold, pulses will be non-palpable. In venous claudication, it's usually towards the night. When you raise the leg, if you raise the leg, the venous claudication will be decreased, whereas in arterial claudication, it will be increasing. And in neurogenic claudications, usually this pain will be starting in the first step.
Yes.
Like in osteoarthritis, whereas in arterial claudication, you have to walk a distance and then take rest. In neurogenic claudication, postural position will be leading to decreased pain.
Very good.
So coming, what is the level of occlusion in your patient from the history? The patient has calf claudication only. There is no gluteal claudication or thigh claudication. So from our history, it's an infrapopliteal disease.
You ask about history of importance. Why it is important? History of importance.
In aortoiliac occlusions, you'll be having importance because of the decreased blood supply to the penile artery, internal iliac and penile artery. So you'll be having importance to rule out
the syndrome.
From your history, can you briefly explain what are the features of critical limb ischemia? Most of the history are suggesting like that. Can you please briefly explain?
Enumerate the
history.
from your history.
If in critical limb threatening ischemia, you diagnose it as critical limb threatening ischemia, right? Can you explain what are the objective features of critical limb threatening ischemia?
We had rest pain for this patient greater than 2 weeks, and we had a gangrene for this patient. Ulceration which led to gangrene. Ischemic changes are present.
Most of the time, you may have to say the objective test.
What are the objective tests?
Like,
Particularly,
When there is ABPA less than 0.4 and systolic pressure of ankle pressure is less than 50
and top pressure is less than
30 and transcutaneous
less than 30. With the angle restriction discussed.
Okay. So also from history, what are the other systemic manifestations? Can you enumerate the systemic manifestations of arteriocclusive disease? We have ruled out postprandial abdominal pain to rule out mesenteric ischemia. We have ruled out loss of consciousness, any blurring of vision to rule out the central nervous system, any carotid retinal artery involvement, etc.
Yes.
Then we chest pain also we have ruled out for any in the coronary vessels, any ischemic changes in them.
And also importance also included.
Importance.
So from the history, what are the risk factors that are related to this your POAD? Risk factors leading to
in your
patient.
Yeah, it's a male patient. History of smoking is the, diabetes is the, dyslipidemia is the, then age. It's a 60-year-old male.
What is the strongest modifier risk factor? In your strongest modifiable risk factor in case of POAD. What happens in smoking? What happens in smoking? What is thromboangiitis obliterans? Can you explain briefly?
Thromboangiitis obliterans is also known as Berger's disease. It's most usually seen in younger age group, which is less than 20 to 40 years, and more commonly in chronic smokers. It will be affecting the distal arteries more, and it will be artery all the layers panarteritis it will be causing.
It's a segmental occlusive disorder, mainly affecting the distal arteries.
Segmental occlusion.
Segmental occlusion mostly may or may not be associated with the superficial phlebitis.
So, can you tell me? Okay. Can you tell me the CT angiogram findings in case of Buerger's disease or thromboangiitis obliterans? There will be corkscrew appearance, spider-like appearance, or tree root appearance.
I'll give you a case scenario. Like there's a young woman with no comorbidities presenting with the arterial occlusive disease. What do you think is the likely diagnosis? Can be mostly Raynaud's
vasculitis.
You can always consider Raynaud's disease. What is it? It's a mostly vasculitis, autoimmune vasculitis. So we have to look for systemic manifestations of vasculitis.
Examination.
Coming to inspection, what are the signs of ischemia or arterial insufficiency you would look for in inspection during inspection? You mentioned in history. There will be dry skin, brittle nails. Then shiny skin will be there. Sparse hair will be there. There will be guttering of the veins.
Loss of subcutaneous tissue.
Loss of subcutaneous fat will be there. Cold to touch.
Very good. Did you look for any deformity? Why is it important?
This patient is having diabetes for a long-term diabetes, so any Charcot's foot deformity can be there. The arch can be lost, hallux valgus.
There can be claw foot, there can be hammer toe. Why is it important is that? Because it will result in recurrent ulcer formation. So we have to address the deformity also.
It is a diabetic patient, and does this patient have diabetic neuropathy? In your case,
the patient did not actually have. It was a very controlled diabetic, so patient did not have any features of diabetic.
How did you look for sensation? Yes. How did you look for sensation in this patient? Diabetic neuropathy. How did you look for?
Sensation that is usually lost in diabetic neuropathy is vibration. So we check for the vibration using a tuning fork, which 128 Hertz tuning fork is used to check for the vibration. Then the 2-point discrimination is checked. Then
anything about monofilament test?
Simple test, monofilament test.
Do you know anything about?
We start with the sensation of touch. That's what we call the monofilament test. We have to take a monofilament and we have to prick at least 10 side. If the patient is not able to take it more than
sensations more than 3. If he's unable to feel sensation for more than 3 areas, that means a significant sensory loss is there. Okay.
So your case is it's a infrapopliteal POAD. So how have you calculated the peripheral pulsations? You're told dorsal pedis is absent, AT and PT is absent. How have you calculated this? And popliteal also.
ETA is palpable lateral to the extensor hallucis longus or the navicular bone or the base of the first metatarsal. PTA is palpable or the middle aspect of the calcaneum, midway between the middle malleolus and the insertion of Achilles tendon. Popliteal artery can be palpated by mainly three methods. First one, make the patient lie in supine position and flex the leg in 135 degree and place the hand over the thumb of both hands over the debatable C and with the fingers palpate the lower part of the popliteal fossa. Then a second method is
Against palpated against the
Palpated against
which
tibial upper end of the tibial condi. Then second method, make the patient lie in the prone position and just flex the knee and relax the popliteal fossa and palpate with the fingers. And third method, hyperextension, palpate with the fingers while extending against the coach and fingers.
Okay.
We can also do push
Femoral
it.
Which is
can be felt below the inguinal
any
midpoint of the
indirect
inguinal
method other than palpation for popliteal artery, popliteal pulsation?
oscillatory movement of the leg.
Yes, that is called swishing test.
Oscillator. Yes.
How would you do it?
You ask the patient to keep the knee of the other, keep the leg of the other, one leg over the other, cross the leg, so the popliteal fossa will be compressed between the other knee.
Sitting posture.
In sitting
Not
posture.
sitting position.
Distract the patient.
Distract the patient. We should.
Yes. So what will be the finding?
Use all
Yes.
the leg oscillating motions.
And if oscillating moment is there, that means pulsations is there.
Pulsation is there.
So you told this the patient is dyslipidemic, yes, right? How do you look? Is there any vessel wall thickening in your case? No, there was no vessel wall thickening in that.
How will you look for vessel wall thickening?
Pardon?
How will you assess vessel wall thickening by palpation?
Roll your hand across the vessel. So if there is any vessel wall thickening, you usually get it.
Usually it slips.
Yes.
You mentioned about bruit, no? What is the significance of bruit in case of POAD? Why is bruit head? What is bruit?
Bruit is an audible thrill that is heard over the stenos vessel. It usually shows proximal. It usually shows turbulence over the stenos.
Turbulent flow. Turbulent flow. Due to turbulent flow of the vessels. That's important word. Yes. And which all vessels do you look for? Femoral, carotid.
Usually we
renal and aorta, abdominal.
Yes. We can look separate.
So, what are the special tests to assess the POAD? You mentioned.
Already mentioned
clinical test.
Clinical test to assess.
You can do the Berger's test. You can do the Berger's vascular insufficiency test, where you ask the patient to lie down and you elevate the limb. So it's usually if there is any if the patient is having pallor in less than 30 degree, it's usually suggestive of an arterial insufficiency. And then you check, you ask the patient to put the leg down to look the capillary filling. That will be delayed in our case. Then the venous filling can also be looked. Guttering of veins can be seen even at 10 degree. You can see the guttering of 10 seconds. You can see.
Okay. Can you explain sunset sign in Burger's test? What is sunset sign?
Sunset sign is a foot drop sign where it is pale. When you put the legs down, it be getting pale.
Pale? No.
You will be getting pale when it's above on elevated state. When you're putting down, it will be becoming
you can see
sunsetting sign.
A pallor will be there while raising the test, and while keeping the foot down, there will be sudden appearance of red or magenta color. Why does it occurs? What is the pathophysiology behind this sunset sign?
Due to gravitational feeling of the vessels when you are putting your legs down.
Okay. So basic idea is that when we raise the foot, there will be decreased arterial supply, there will be anaerobic metabolism, there will be carbon dioxide and lactate production, which act like vasodilators, there will be vasodilatation. So when we keep the foot down, there will be increased blood flow towards the foot. So that's why the reason for sudden increase in color of the appearance of red or magenta color in foot on lower.
We are halfway through the mark.
5 minutes. 10 minutes. 10 minutes.
Can you briefly explain what is disappearing pulse syndrome? The disappearing pulse syndrome. Did you heard about that?
Disappearing pulse. Yeah. Disappearing pulse means usually when you're in a case of you're suspecting ischemic case and if you're palpating, you'll be getting the pulse. You make the patient exercise. After exercise, the patient's pulse might be disappearing.
Because of
Why?
vasodilation that can
Actually, we can confirm our ischemic, the limb is ischemic. First, you're getting a pulse, then you make the patient exercise.
Because of increase in circulation. Okay. There will be a vasodilation while during the increase in circulation that can lead to increase in
So
the
the blood will
pulse.
be going.
Yes.
So, can you go with the what's pressure indexes? What is a single plus pressure index? If you are given only chance to look for only one pressure index, which one will you go for?
In our case, we'll be looking for toe breaking index because our patient is a chronic diabetic.
Calcification can occur. So in toes, the risk of calcification is very low. So we will look for toe.
Because ABPI will be falsely elevated in our patients because of medical.
So what is that condition called? What happens in diabetes? What is the condition called?
Median sclerosis.
Monkey bone sclerosis. There will be deposition of calcium in the medial layer so there will be calcification. Any other investigation? Have you heard about transcutaneous oxygen saturation, TCPO2? How will you assess that?
We will put the a probe over the intracutaneous. We will assess the transcutaneous by putting a probe over the intracutaneous area. If it is
Simply
less
just
than
put a
30,
probe
that
like that,
indicates
or
it is ischemic.
we simply put a probe like that. We need to preheat it, no? Heated probe is placed over the heated probe is heated so that there will be vasodilatation and we can assess the diffusion oxygen pressure by that. So what is the significance of TCPO2?
It will be decreased in cases of ischemia and it's important in Wi-Fi classification. We just wound ischemia and foot infection. In that ischemia, we can classify according to the transcutaneous pressure. It's less than 30.
This
patient, how will investigate? Okay.
If this patient came to your OPD, your clinical patient, how will you investigate from the beginning? Like in order, how will you proceed with this patient? As the patient is having severe respiratory, we will first give analgesics to the patient, and in order to complete the clinical evaluation, we will do a handheld
management.
Investigation, we can complete the clinical examination by doing a handheld Doppler, and we can also we can do an ABPI. We can also do an arterial duplex test, and in order to decide how to do the revascularization, we go according to the plan strategy.
Sorry to interrupt. But before you will do routine blood investigations, no? You have to do routine. You have to see the diabetic status, diabetic control, HbA1c, lipid profile, lipid profile. Okay, after that,
Yes. And patient is having dyslipidemia, so fasting lipid profile is also done. HbA1c, FBS all done, and then RFT is also checked because we need creatinine value to further proceed with the CT angio or not. And patients are long-standing diabetic patient is also taking metformin, so it's also important that we stop metformin if any renal reason is there because it will cause lactic acidosis also. Cardiac standards has to be measured using ECG and an echo has also has to be taken. The patient does not have any dyspnea on exertion or any symptoms suggestive of a cardiac disease. Echo is not a must, but if you're doing an open surgery or a big, if you're planning for a big vascular surgery, then you've got to do echo also. And then we'll be proceeding with the CT angio. If you're planning for revascularization.
Okay, now going for it. Okay. So, what are the non-invasive imaging options you have?
Non-invasive imaging options are.
You have already mentioned before. Just
you have started with those.
Handheld Doppler, no? Start handheld Doppler.
What will you look in handheld Doppler actually?
Pardon?
In handheld Doppler, what are the features you are looking?
You're looking.
What are you looking for? While doing handheld Doppler.
Confirming our clinical examination of the pulses, we will be confirming with the handheld Doppler. It's important we rule out acutely the pulse status we can rule out, and then we can in the most handheld Dopplers there will be sound waves also. You can clearly hear the monophasic, biphasic, or sounds also. Using the sounds also you can diagnose it. And the level of
We may have to go for
occlusion, you
duplex
can
scan
find it
for
out.
this condition. And Doctor, we are looking for the pulse of the patient mainly, and we can also assess the blood pressure and everything. For the physicity, we may have to go for duplex scan, basically. And Doppler is a preliminary scan.
And there is a clinical part of clinical examination. It's usually done for noticing what all pulses are present or not to confirm our clinical examination. What is the base principle of duplex? What are the components of duplex scan?
What is duplex? What is duplex scan?
The components of duplex.
Duplex scan contains two investigations actually. One is B mode ultrasound and Doppler. B mode ultrasound gives vessel wall anatomy, and whereas with the Doppler we can measure the velocity of the blood flow, turbulence, and other flow characteristics and directions can be measured with the B mode Doppler.
What is the normal wave pattern you see in a Doppler normal study? Huh? What are the waves? Can you elaborate?
Pattern where the first wave is the systolic wave and the next wave is the
Transient late early diastole will be there. Then there will be antegrade late diastole.
So which one will be firstly lost in case of POAD? What will be lost? It will be changed triphase to biphase to monophase.
The second transient.
Early diastole will be lost.
Which one is a gold standard investigation in case of the peripheral vascular disorder?
Gold standard.
Gold standard. Pardon?
Gold standard would be digital subtraction angiography.
What is the principle of digital subtraction angiography? What happens?
In digital subtraction angiography, when you do, you can subtract all the other bone substances, muscles, subcutaneous tissue, all can be subtracted, and you can see the arterial, just the vascular.
We are eliminating non-contrast image.
Why do you think it is gold standard? What is the advantages for DSA over CT angio or MR angio?
If DSA is done, you can actually do the therapy. Therapeutic also can be done too.
And it's a dynamic study where you can assess where you can quantify the lesion if there is any stenosis or a complete total occlusion of the vessel.
Okay. From your case, how will you proceed further?
If
You have
considering
just
the
2
patient,
minutes more. You have just 2 minutes.
so how will you proceed?
We will proceed according to the plan strategy. Plan includes patient risk, then limb severity and anatomy. In patient risk, we will grade according to high risk and average risk patients. And in that, we will look for the post operative mortality and 2-year surveillance. And then in limb severity, we will classify it according to the Wi-Fi classification. Then we will look for the target arterial path, and then we will look the anatomy by using the glass classifications.
To begin with management, first line of management is modification of lifestyle.
Lifestyle modification, like
cessation of smoking, diabetic control,
exercise, followed by your
this sort of thing you have to mention. You can mention it like in a structured manner, whether they are claudicants or they are having critical limb threatening ischemia. Claudicants will be mostly medical management.
Critical ischemia. So in our case, we had to do a revascularization procedure. So we proceeded with all this. If it is just not critical, just a claudican, you can proceed with medical management. Like we can give an antiplatelet ecospirin 75 milligram OD and add the proper statins according to the fasting lipid profile. We can change the statin levels. We can increase the statin dose. And if it is we're not doing a surgery, we can also add silastazole and pentoxicillin is old medical management. It's not usually done to.
Mechanism of action of silastazole.
Can you please say?
Briefly explain.
Explain the mechanism of action of
silastazole. You told about silastazole, no? So how does it act?
So the phosphodiester 3
inhibitor, which will increase the cyclic AMP.
Yes,
which will
very
increase
good.
the platelet aggregation. And
so how will you proceed with surgical management? Which surgery will you
endoluminal or open surgery? Last question.
In our patient, we actually graded the patient according to plan strategy, and glass, it was actually a glass 2. So we proceeded with the endovascular procedure in our case. We had a target arterial pathway, so we did a tibial angioplasty for this patient. After the tibial angioplasty, we surveillance for the post-op pulse we have checked, and since there was a pulse, and we waited for the zone of demarcation, and then did the reamputation of the left gangrenous toe. And we post-op we continued the antiplatelets and statins also.
Thank you very much. We move to the, thank you very much.
Thank you, sir.
We move to the examiners for their comments. First, we will have Dr. Rajesh. Please unmute, sir.
Okay. Am I audible?
Yeah, yeah, very much.
Okay. First of all, presentations were very nice. I'm saying the presentations are very nice, but I have my own reservation on your role as teachers, both teams. I will tell common things that both teams have done, not as a good teacher. One is both people were very much tensed and they're looking, they're actually frightening the students by questions. That is the first thing that is common for both teams. Then before asking questions, a teacher should know the answer first. So many times I felt that teachers are not sure about the answer. That's why when the student is answering, they are actually interfering too much and going on to the next level of questions. So when you are presenting, when you are listening to a student, you should listen all the parts of presentation, like general features, then clinical presentation, history, clinical presentation, then personal history, family history. All things has to be assessed whether they are analyzing it in the correct way. Regarding the team Lood, when the Thrissur were presenting, their diagnosis was benign disease, but all your questions were based regarding malignancy, features of malignancy. You are not giving any what do you call? You are not allowing them to justify their diagnosis as a benign cause of gastric obstruction. Some questions were not connected to each other. Say, I will just quote an example. You are asking complications of gastrojejunostomy and leak. What is the commonest site of complication? They are not having any answer for that. Then immediately one person was saying that it is leak from a gastrectomy site. You haven't mentioned about gastrectomy. You are asking about gastrojejunostomy. And what you thought was, what you meant to ask was complication of gastrectomy. Then immediately after that question, you asked about GIST. See, GIST usually never produces gastric ulceration to start with. Sometimes there can be a rare presentation of GIST as goo, but commonly it is asymptomatic or sometimes can be bleeding. So I thought your question was just to ask question. You are asking like that. Regarding Thrissur Medical College. Again, there are some common factors like you are not be pleasant to the students, and one of the person was not allowing others to ask questions. The person was always interfering with the question. Don't ask that question. Again, you are saying that means you are producing some confusion to the students, and again. You are asking one area, when you are asking a question to a student, first, by asking the first question, you can assess whether the student knows their answer or not. Suppose the student is not knowing the answer, there is no need to further evaluate on the same question. You are asking about sunset sign and it was very clear that they were not sure about the answer. Then next question was, what is the mechanism of sunset sign? Again, you are confusing the student and you are not trying to make out what the student exactly knows. These are small things that I have noticed. After all, it is a good show, and I think we'll find it very difficult to assess who is the best teacher among you two. Thank you.
Dr. Srinivasan, thank you, Dr. Rajesh. Dr. Srinivas.
Good evening, sir. Am I audible?
Yeah, very much.
I think between the teams, I would like to choose Dr. Rajesh because he has very thoroughly examined both the teams. I don't have much of comments, but thing is, both teams were just rushing through their presentation as if to finish early and then have more time for discussion. But it is better you present it in a slow and methodical way. Second is, don't interrupt your teammates and the other team. At times, we just don't understand who is asking, which team is asking the question, and the same team is answering or the different team is answering. So very difficult to choose between you two teams. You have done excellent preparation, gone through in depth in both subjects. and it is good. And as part of the organizing committee of Casicon, I welcome you all. Next week we can meet in Kannur. Thank you, sir, and thank you, team.
Thank you very much, Dr. Sam Christy Maman.
Regarding both teams, the presentations were good, but as Rajesh and Srinivasan was saying, teammates, it is a team play, so you have to give a chance for the others. You have to wait for the others to speak. That is my comment. Thank you.
Thank you very much, everybody. Ranjan, you can have a closing word.
Sir, it was another wonderful 2 matches, and all the teams fought well and very well assessment from the values also. So let us the values decide who had done the best, and all the best once again for the participants. Thank you, sir.
Mathu, anything more from your side? Dr. Mathu?
It was very, Rajesh's assessment was very critical and very to the point, I think. So I think of all the judges from yesterday and today, Rajesh was the most critical because I even last year and we have been. Can you hear me, sir?
Yeah.
We can hear you, Madhu.
Yeah, no. Sometimes students forget that it's like sometimes students forget it's a competition about who is a better teaching team. So we need to keep on reminding them this is the concept behind this match is teachers of tomorrow, not students of tomorrow. That's all, sir. Thank you, sir.
Thank you very much, and let's hope for the results from the judges at the earliest, so that they can, whoever teams goes to the next stage can have a slightly better preparation. All the best to all teams. Thank you very much.
Good night, sir.
Good night.
Good night. Good night. Thank you.